Good morning, and welcome to our second in our series of Data You Can Use webinars. My name is Joanna Stoms. I will be the moderator for today's webinar. Today's webinar is Obesity-Related Cancers in Pennsylvania, Incidents, Research, and Solutions. And it is being presented by the Data Advisory Committee, which is a committee of the Pennsylvania Cancer Advisory Board. Today's presenters are David Sauer, Director for the Center of Obesity Research and Education from Temple University, Nathan Wirth, a Statistical Analyst for the Pennsylvania Department of Health, and Tiffany Brandstetter, Obesity Prevention and Wellness Section Chief for the Pennsylvania Department of Health. Contributors to this webinar were Wendy Aldinger, Cancer Registry Administrator, and Alan Flegel, Statistical Analyst Supervisor for the Pennsylvania Department of Health. We just have a brief disclaimer. Funding for this webinar was made possible in part by the Centers for Disease Control and Prevention. The views expressed in written conference materials or publications and by speakers and moderators do not necessarily reflect the official policies of the Department of Health and Human Services, nor does the mention of trade names, commercial practices, or organizations imply endorsement by the U.S. government. I'd also like to thank the Northeast region of the American Cancer Society for hosting this webinar. First, I have a few housekeeping details for the webinar. All attendees will be placed in listen-only mode. A copy of today's presentation may be downloaded from your handout section. Questions may be asked by typing into the chat box on the right side of your computer screen. We will attempt to answer all questions at the end of the presentation. We will not be taking questions at the end of each of the sections. However, if we run out of time, all of today's questions and answers will be recorded and emailed to participants after the webinar. And also, please take a few minutes at the end of the presentation to complete a very brief survey. Your feedback is very important to us. First, I'd like to introduce Nathan Wirth, a Statistical Analyst for the Division of Health Informatics for the Pennsylvania Department of Health, and he will be speaking on obesity, diet, and exercise in Pennsylvania. Nathan?
Good morning, everyone. We'll start the webinar looking at obesity from a public health surveillance angle. So overweightness and obesity are associated with at least 13 different types of cancer, ranging from colorectal to myeloma. In 2015, these cancers made up 43% of all cancers diagnosed among Pennsylvanians aged 50 to 74 and 57% among those aged 18 to 49. Many things are associated with cancer, but keeping a healthy weight is one of the most important things people can do to lower their risk of getting cancer. From 2006 to 2015, the age-adjusted incidence rate of invasive cancers not associated with obesity decreased by a little over 8%. In contrast, obesity-related cancers, other than colorectal, rose by 7%. Colorectal of tumors that have become invasive. Even if we exclude thyroid cancer, which has seen an unusual surge of incidence over the past 10 years, the rate of the other obesity-related cancers combined would still have increased by 5%. Specifically, incidence rates increased for pancreatic, liver, and breast cancer and multiple myeloma. During the 2002 to 2004 period, 24% of Pennsylvanians were obese. By the 2014 to 2016 period, this had increased to 30%. The prevalence rate increased across all regions except Cumberland and Perry counties, which had the same rate in 2014 to 2016 as they did in 2002 to 2004. The western counties in Philadelphia consistently had higher prevalence of obesity. By 2014 to 2016 period, Adams, Franklin, Fulton, and York counties also had much higher rates than the state average. Obesity is not found equally among all races in Pennsylvania. According to the BRFSS, the Behavioral Risk Factor Surveillance, or the the behavioral risk factor surveillance survey. Okay. Sorry, the BRFSS. Non-white residents are much more likely to be obese. An estimated 3 out of 10 white adults were obese, compared to 4 out of 10 Black or Hispanic adults. And no matter the race, all Pennsylvanians are more likely to be overweight than not. An estimated 65% of Pennsylvanians had BMIs of 25 or higher, making them overweight or obese. Where adults use absolute BMI measures as thresholds for classifying as obese or overweight, children are classified according to age, and these age-specific thresholds are set by the CDC as part of their clinical growth chart. So, using data that was taken from large surveys of school children, during the 2015 to 2016 school year, 34% of children screened in grades kindergarten through 12 were either overweight or obese. For children between kindergarten and 6th grade, the rates of overweightness and obesity hadn't changed since the 2008-2009 school year. However, the rate among those in grades 7 to 12 increased slightly. The county health rankings that are provided by the Robert Wood Johnson Foundation include a food environment index. This ranks counties on a scale of 0 to 10, 10 being the best, based on the accessibility and reliability of their food sources. So looking at these rankings, in general, the eastern and southern counties scored higher than the rest of the state. Philadelphia is the noticeable exception, having the lowest score of all counties. Butler and Elk counties in the west have relatively high scores compared to their neighbors. In comparing this map to the previous ones showing obesity prevalence, the most noticeable difference is in south central Pennsylvania. Adams, Franklin, Fulton, and York counties. This area had a higher obesity rate than the state average, but they scored well in the index. The United States Department of Agriculture identifies food deserts as census tracts that are low income and low access to food sources, or LILA, L-I-L-A. This map shows the LILA tracts, where low access is defined as a large number of residents being more than 1 mile from a supermarket in urban tracts, or more than 10 miles in rural. So only 6% of all Pennsylvania residents were in LILA tracts in 2010. This is much lower than the national rate of 17.7%. While the area covered by LILA tracts is split close to even between rural and urban areas, the urban tracts actually account for 95% of all LILA residents in the state. While many cities had at least one LILA tract next to them, most in the western part of the state had multiple. In the east, Allentown and Harrisburg had far more LILA tracts nearby than other cities close to them. So physical activity is a pillar of maintaining a healthy weight. Age and income are some of the largest predictors of leisure time physical activity. The proportion of Pennsylvanians who don't exercise in their free time only increases with age. Those aged 45 to 64 are 62% more likely to be inactive than 18 to 29-year-old residents. The differences are even greater when you examine by income. Those around the poverty line are over 1.5 times more likely to be inactive than those who are affluent. And the final measure is from the county health rankings. It's access to places for physical activity. These places can include parks, gyms, pools, YMCAs, and similar locations. Looking at the map, counties with large cities have high rates of access. Forest County has a high rate because it is almost entirely covered by the Allegheny National Forest, which counts as an exercise location. Juniata, the counties northeast of Allegheny, and the counties in the northeast tip of the state had the lowest rates of access. But keep in mind, these data only reflect the barrier of distance. They don't account for the costs of using these private facilities.
Thank you, Nathan, for that very interesting and informative presentation. Our next presenter is Tiffany Brandstetter, who is the Obesity Prevention and Wellness Section Chief for the Pennsylvania Department of Health. And she is going to be speaking about obesity prevention and control strategies that are being undertaken by our Pennsylvania Department of Health. Tiffany?
Good morning. Thank you, Joanna. And thank you, Nathan, for setting the stage for this discussion. All right, so, let me go back one. Okay, so just for a little history, the Obesity Prevention and Wellness Section was established in 2009. We are a 100% federally funded program within the Pennsylvania Department of Health. And the section strives to implement approaches to promote health and prevent obesity and address associated risk factors of poor nutrition and physical inactivity. Our current strategies are funded by the Preventive Health and Health Services Block Grant and 1305, or State Public Health Actions to Prevent and Control Diabetes, Heart Disease, Obesity, and Associated Risk Factors and Promote School Health grants. And so with the 1305 funding, we primarily focus on environmental approaches to address obesity. These are improvements in social and physical environments that make healthy behaviors easier and more convenient. These types of interventions support and reinforce healthy choices and healthy behaviors and make it easier for people to make healthy choices, or making the healthy choice the default choice. So under the 1305 grant and with block grant funding support, we're working in multiple sectors. We work in early care and education to implement healthy nutrition environments by implementing nutrition standards via policy and practice changes, and we promote and increase physical activity and adoption of physical activity standards. And I'll be digging in a little further into these approaches here in a few minutes. We also work in schools to promote and implement increased quality physical education and physical activity with a focus on implementation of comprehensive school physical activity programs to provide opportunities before, during, and after the school day for students to achieve the recommended 60 minutes of daily physical activity. And we're also working in schools to create supportive nutrition environments by implementing policies and practices that create a supportive nutrition environment. In communities, we work to increase access to healthy foods by providing access to healthier food retail. We're also working to increase physical activity access and outreach by creating or enhancing access to places for physical activity with a focus on walking. And we also promote physical activity in work sites and promote the CDC Worksite Wellness Scorecard as an assessment tool for work sites. We're also working with health systems to increase access to breastfeeding-friendly environments and implement practices supportive of breastfeeding in birthing facilities. And so to dig a little further into our approaches for early care and education, over the past 5 years, we've been implementing the Pennsylvania Nutrition and Physical Activity Self-Assessment for Child Care that I'll refer to as PA NAPSAC moving forward. As you heard from Nathan, childhood obesity is a growing epidemic, not only here in Pennsylvania, but across our nation. 41% of U.S. children aged 0 to 5 years are cared for weekly in non-parental arrangements, such as child care centers or family child care homes, pre-kindergarten classrooms, and Head Start programs. Caring for our children, which has national health and safety standards and guidelines for early care and education programs, is a subset of the National Health and Safety Performance Standards guiding obesity prevention efforts in early care and education. And the National Resource Center for Health and Safety in Child Care and Early Education has identified 47 of the 250 caring for our children components as having a high impact on childhood obesity prevention. Currently, Pennsylvania fully meets only 4 of the 47 standards in our current licensing regulations. And So the NAPSAC really complements implementation of those standards at a local level within individual licensed centers within Pennsylvania. So the NAPSAC is a free, web-based continuous quality improvement intervention designed to help child care providers improve the nutrition and physical activity policies and practices within early child care settings. The original NAPSAC program was developed in 2002 via collaborative effort by the University of North Carolina, Chapel Hill, and North Carolina Division of Public Health. And it's an empirically validated, sustainable, policy-based intervention designed to improve children's nutritional behavior and physical activity levels within early care and education. NAPSAC program staff provide the training and technical assistance needed for early care and education staff to implement formal policy changes and practices. In turn, these policies improve the variety and nutritional quality of food and beverage, feeding environment, including teaching mindfulness and eating, staff role modeling of healthy eating and physical activity, breadth and quality of indoor and outdoor physical activity, staff practices related to physical activity and behavior management, and reducing sedentary behavior, including reducing screen time. The department collaborates with the Keystone Kids Go work group to promote PA NAPSAC, and the Keystone Kids Go consists of staff representing numerous organizations, including the Office of Child Development and Early Learning, or OCDEL, as you may know it, Head Start, USDA Child Care Food Program, or CACFP, American Academy of Pediatrics, our quality rating improvement standards in Pennsylvania, Penn State Cooperative Extension, and other early care and education partners from across the state. During the Pennsylvania Quality Rating and Improvement System, or Keystone STARS, as you may know it, revisioning this past year, we achieved support for PA NAPSAC and child care health consultants as the PA NAPSAC CQI, or Quality Improvement Process, satisfies now specific Keystone STARS performance standards and provides bonus points to centers achieving a STAR 3 or STAR 4 rating. So NAPSAC is a continuous quality improvement tool, as I had mentioned, and the intervention is designed to help child care programs achieve best practices in nutrition and physical activity practices, environments, and policies, as I had shared. And child care centers complete an assessment to measure the nutrition and physical activity environment, and then are provided automated feedback regarding areas for improvement and resources, such as professional development modules that are available within and outside of the PA NAPSAC tool. With that feedback, they create an action plan and implement it, and they reassess after a period of implementation and reflect on that. So the department does incentivize through our grant some participation in PA NAPSAC. So as you heard, as I shared, we provide assessment, professional development, but we also provide technical assistance through this program to licensed centers on nutrition standards, physical activity, breastfeeding, and screen time. And the practice changes are sustained through the policy development to educate, promote, and provide children, staff, and families with healthy nutrition standards, increased physical activity, breastfeeding-friendly environments, and limited screen time. So with the grant funding, we provide $500 mini grant incentives to 100 centers, licensed centers annually. And that money can be used to purchase supplies or portable equipment that's useful in policy implementation. We partner with the Department of Education and Human Services through OCDEL, as well as Tuscarora Intermediate Unit and the Early Childhood Education Linkage System, or EXCEL, to implement the PA NAPSAC and participating ECEs. Licensed early care and education programs are solicited to submit a mini grant proposal, and then when selected, they participate in a web-based orientation webinar, and they also then move through the CQI process with additional technical assistance that's provided by both TIU, that's for our intermediate unit, and the Pennsylvania chapter of the American Academy of Pediatrics through EXCEL, through the Child Care Health Consultants. The technical assistance provided by the Academy includes online review of written policies and policy action plans, and then additional supports are provided as requested, including conference calls, and then more intensive, including some on-site consultation, is provided to 40 centers on policy development. Again, as I mentioned, there is additional professional development available through 8 web-based professional development modules built within NAVSAC, and also referral to resources outside of NAVSAC as well. And so here's just a map of the early care and education centers and our reach to date. So over the past 5 years, we've reached 244 early care and education programs located in 49 out of 67 different counties. And this has an impact on an estimated over 16,000 children, staff, and families. And then we've had greatest policy improvements in both the written policies for both nutrition and physical activity, as well as requirements for staff and families to receive professional development and training in healthy eating and physical education. And so I'm going to quickly touch on some additional outcomes, but there's a wealth of information on these slides. I'm just going to touch on kind of our greatest outcomes. So the PA-NAVSAC has 7 nutrition scales: fruits and vegetable, meats, fats, grains, beverage, feeding environment, menus, and variety, nutrition education and professional development, and policy implementation, consisting of 41 items. And then we also have 6 physical activity scales, including time provided, indoor and outdoor play environments, teacher practices, physical education, and professional development, policy implementation, and screen time, consisting of 76 items for a total of 117 items. Our evaluation found significant improvements occurred across all nutrition and physical activity policy scales over a 4-year period, and these slides highlight those changes from pre and post implementation. The greatest improvements on the nutrition scales were found in the establishment of written nutrition policies and policies requiring EC staff and families to receive training in healthy eating. And then for physical activity, the greatest impacts or improvements were found in policies related to teacher practices. So not taking away physical activity as a punishment, posting social marketing materials in a classroom, etc. But these are policies requiring early care and education staff and families to receive physical activity education, and in the establishment of written physical activity policies. We do feature 20 child care innovative practices from this work in 4 focus areas, and those videos can be found on the Pennsylvania NAVSAC website. Moving on to our school initiatives, we refer to it as Building Healthy Schools. And, we see schools as a logical environment to implement obesity initiatives given the number of students enrolled and the time spent in school, so 180 days, 7 hours per day. And there's also a growing body of research and studies that support healthy kids or better learners. Students have daily access to healthy foods, nutrition education, and physical activity, gain lifelong healthy habits, and are better prepared to learn and succeed academically. While we invited 15 targeted school districts to participate in Building Healthy Schools, 13 joined the program, and this was based on BMI data, so highest quartile of obesity rates and low income tracts, and that was stipulated by the 1305 grant. And then we had 2 additional districts join us as affiliate districts through statewide professional development that we provide through the program, where they had already implemented some of the steps required in the program, such as like assessment, to be able to develop an action plan and hit the ground running. Building Healthy Schools, we implemented in partnership with the Penn State Pro Wellness. Our other partners include the Department of Education, Alliance for a Healthier Generation, Action for Healthy Kids, and as well as the Department of Conservation and Natural Resources. The program was developed to help schools create supportive nutrition environments and increase opportunities for physical activity. It starts with a representative active wellness council and identifies a champion, which has to identify a champion to lead wellness initiatives for the district. An active wellness council is an integral piece of this process, and active is defined as meeting at least 4 times per school year. And this includes a team of administrators, staff, teachers, parents, community members, and students. And they work together to complete an inventory to determine what current health and safety and wellness practices are in their district. And by assessing current practices and policies, wellness teams then identify areas for improvement. Using the results, teams develop a plan to take action to implement initiatives or policies to increase access to healthy foods and water, limited access to unhealthy foods and beverages, and increase opportunities for physical activity. This action plan becomes essentially a roadmap to implement initiatives that make school buildings healthier for students and staff. And we work with each district over a period of 2 years to accomplish planning, assessment, and implementation, as well as evaluation. And throughout this process, they're provided hands-on technical assistance. Essentially, our team becomes an extension of their wellness council, and then we're also providing several statewide professional development opportunities as well that they can continue to participate even beyond the 2-year period. This next slide touches on evaluation and outcomes. It includes a list of our data sources and some of our Building Healthy School measures. And thanks to the effort of all of the wellness councils, more than 35,000 students in Pennsylvania are enjoying healthier school environments as a result of building healthy schools. And to create healthy places for students to learn and grow, Building Healthy School participants implemented initiatives such as aligning food served and sold outside of the cafeteria with federal smart snack guidelines. They've instituted healthy celebrations and non-food reward practices. They've increased water access and promotion of drinking water. They have also added nutrition education to health curriculums. They've added classroom activity breaks, and they've also incorporated getting kids active before school through open gymnasium practices. These new practices will be sustained by changes to school wellness policies, with 89% of participants reporting revised wellness policies. And as a result of participation in Building Healthy Schools, 100% of school districts have agreed that they have plans to sustain their wellness councils beyond the implementation period. So we're very excited about that. And so moving on, I wanted to touch a little bit about our strategy we call the Pennsylvania Healthy Corner Store Initiative to increase access to healthy foods and beverages. And we have a focus on foods in corner stores. This is implemented to 10 of the most populated cities across Pennsylvania. And we've partnered with the Food Trust to provide training and support to dedicated community partners. Partners work with store owners to increase inventory of healthier food and beverage in over 150 stores throughout Pennsylvania. Accessibility and affordability, as you heard a bit from Nathan, influence what consumers eat. And in addition to those LILA areas that Nathan had talked about, residents face barriers such as lack of transportation to shop at stores with healthy foods, and then they shop at local corner stores which may lack nutritious options. Also, we have lots of data that support what it looks like when children visit corner stores, such as walking to and from school, buying on average 360 calories in chips, candy, and sugary drinks when that occurs. So when we work with a corner store, and these are some pictures of some changes in the corner stores we've worked in, participating stores choose at least 4 healthy food products based on the dietary guidelines for Americans to maintain a stock of and sell. Signage is displayed to guide customers towards making healthier decisions and identify healthy corner stores that are participating. Educational resources and training is provided to store owners on how to organize and display products to highlight healthier options, how to increase healthy inventory and sell healthy products to increase success, because we really want to invest in this being sustainable, and for it to be sustainable, we need the store owners to be successful in selling the items that they're stocking. And then stores may also qualify to receive modest environmental changes in the way of shelving and refrigeration to enhance display and storage of new healthy inventory to sustain changes in the long term. Community partners are now working with store owners to implement in-store nutrition education, health screenings, and other community events with 19 corner stores throughout Pennsylvania. And in many cities, we're partnering with SNAP Ed to provide the nutrition education, also aiding in sustainability. Residents will learn about nutrition topics, experience a taste test, and be given a tour to see the healthy options. Interested shoppers will be directed to free health screenings, including blood pressure and BMI checks. And this is an opportunity to really educate shoppers on nutrition and bring their own health, to the attention and the healthier options available in the store. So in terms of results, like I said, we're working in 150 stores. Through the first 4 years of the program, store owners received over 237 trainings. And then participation led to healthy product additions from every area assessed. So more than 85% of stores added whole grain products, 81% added inventory in fruits and vegetables, 63% added healthy protein sources, and 44% added low-fat dairy options. So we were, again, happy with those outcomes. And just quickly to move through some work that we're doing around physical activity in communities. According, as Nathan shared some of the information about inactivity, CDC kind of has this prescription for physically active communities that includes 3 main components, and that is designing communities and streets that make being physically active safe and easy for people of all ages and all abilities, development or enhanced access to places for physical activity, with a focus on creating walking trails or connectivity, and then delivering community programs that help children and adults be physically active, so social supports such as walking groups or youth recreation programs. But overall, people need a safe and convenient place to be physically active. And we partner with the University of Pittsburgh and Center for Sustainable Transportation and Infrastructure to scale WalkWorks to target communities to provide opportunities for physical activity. And this really focuses on planning, implementation, and marketing sustainable walking opportunities to walk and walking groups that also provide social supports. And so community-based organizations lead implementation at the local level, and the University of Pittsburgh provides technical assistance around communities identifying and implementing not only the walking routes and social supports, but also implementation of policies related to improving pedestrian transportation in the built environment. And one of those policy changes might be, for example, a city developing a complete streets policy. And so through WalkWorks, access to local walking routes and social supports are increased. They identify, map, and promote safe walking routes that are accessible to people of all ages and abilities. They establish and promote guided community-based walking groups. They help schools develop walk-to-school programs when applicable, and they also provide education to support local policy change related to pedestrian transportation in the built environment. And so the next slides provide some examples of what the some of the materials look like that are developed. And once the walking route is finalized, partners identify key points of interest to highlight along the walking route, and this card is developed to include in a packet that walkers receive. And this is a route in Northampton County, which borders New Jersey. And you can note a park, a school, a church, and other possible historic sites, and an urban farm, all within 1.5 miles of this route. And then a few sentences are provided about each point of interest to provide some historical perspective about the community. And once this is completed, WalkWorks signage is also installed, and then they promote the walking route via press releases and other communication activities. They educate about the need for policy change to support the built environment. And then they organize kickoff events that include local government officials. Over the years, WalkWorks has evolved to really have a greater focus on plans and policies to support the built environment. And we've expanded the scope of WalkWorks to focus on this area. We provide grants to municipal or similar local government entities to develop transportation plans with an emphasis on walking and biking, and or develop policies such as Complete Streets or Vision Zero that include language in support of environmental changes for enhancing places for physical activity with an emphasis on walking. These grants include both funding and technical assistance. And so this is a map that shows where WalkWorks routes have been established along with policy achievement resulting from WalkWorks, and where we're currently working on with 4 communities on those master transportation plans. And then real quickly, I just wanted to touch on a initiative that we fund primarily or only solely through the block grant. This is a more health systems focused effort. So it's called EPIC, or Educating Physicians in Their Communities, Pediatric Obesity Evaluation, Treatment, and Prevention in Community Settings. And it's really delivers an educational curriculum on childhood obesity screening, treatment, and prevention within the primary care practice settings in Pennsylvania. The training curriculum was developed by public health professionals, physicians, and healthcare providers, and it's meant for physicians and healthcare providers as well as the entire practice site. So we provide trained teams of physician and registered dietitians from that community to meet with the physicians and the entire practice staff at pediatric and family medicine offices and a variety of professional conferences to provide free CME or CEU updates on current obesity prevention research and the American Academy of Pediatrics Expert Committee recommendations on overweight and obesity. And the training addresses sustainable protocols to assure universal childhood obesity screening of all children, identification of appropriate patient education materials to prevent and treat overweight children, and refer patients to community resources such as weight management programs and registered dietitians. And between June of 2011 and December of 2017, we've partnered with over 60 physician presenters and 68 registered dietitian presenters to provide 349 EPIC pediatric obesity presentations across 60 counties, reaching just shy of 8,000 participants in 940 sites. And this has reached an estimated nearly 3 million pediatric patients in our state. And then just really quickly, I wanted to touch on kind of what's coming next. And so we're in the process of planning and writing our next competitive 5-year funding opportunity that will build on the foundation of the work that I shared. And we are planning to work, we do plan in collaboration with the Division of Cancer Prevention and Control. And we will be working together to implement food service guidelines in work sites and community settings. And we will also continue to strive to address obesity in disparate populations, and certainly we accomplish this by targeting strategies to counties with the greatest need and ensuring that materials are and approaches are culturally sensitive and appropriate. I know I went through that material really quickly, so I'll be happy to answer any questions. Or you can reach out following the webinar at any time. And I also just wanted to take a moment to acknowledge and thank the Obesity Prevention and Wellness Section team for their contributions to this work and these slides. Thank you.
Thank you, Tiffany, for that very comprehensive overview of what the Pennsylvania Department of Health is doing around obesity in Pennsylvania. Just a quick reminder that for those of you that have joined the webinar a little bit late, that if you'd like to download today's presentation, you're able to do that from the resources section handout section on your toolbox. So you're able to download today's presentation and slides. So our next presenter is Dr. David Sauer, and Dr. Sauer is Associate Dean for Research and Professor of Social and Behavioral Science, and the Director of the Center for Obesity Research and Education at the College of Public Health in Temple University. And Dr. Sauer will be presenting on obesity and cancer and approaches to weight loss treatment. David?
So thank you for that very nice introduction. So Nathan and Tiffany have done a really nice job of setting the stage for me. I'm now going to take us into a little bit of a deeper dive, looking more specifically at what types of interventions are available for persons who are overweight and who struggle with obesity, and in particular, how we're seeing an increasing amount of momentum at seeing those interventions delivered to individuals who are cancer survivors or being used and recommended to those who are at greater risk for cancer. So we saw a very similar version of this slide at the beginning of the presentation when Nathan was speaking, where he talked about the different types of cancer that are affected by obesity. What's particularly striking to me as we look at this slide is that when I started working in this field about 20 years ago, we really didn't talk very much about the relationship between obesity and cancer. We focused much more on things like diabetes and hypertension, the comorbidities that come to mind first and foremost. But there's been much more study done that has suggested that excess body weight is associated with the increased risk of cancer, as well as an association between obesity and the subsequent risk of a cancer recurrence. And there's some compelling literature that's come out in the last few years that has suggested that the massive weight losses that we typically see with interventions such as bariatric surgery, which we really won't be talking about today, are quite impressive in terms of decreasing the risk for cancer recurrence in individuals who are at particularly high risk for those things. So we've got some encouraging evidence to suggest that if we're successful in helping people lose weight, we can reduce their risk of cancer and improve their outcomes long term. I'm trained as a clinical psychologist, so many people assume that when I think about the factors that contribute to the development of obesity, that I'm going to focus all of my attention or much of my attention on cultural and psychosocial factors at the individual level. In reality, my colleagues and I spend a lot of time talking about some of the environmental factors that contribute to the development of obesity. Things such as what's been described as the toxic food environment, where high calorie, high fat, high sugar foods are readily available and often at lower cost than healthier food options, as well as the impact of the built environment that oftentimes, and unfortunately, will de-emphasize or de-incentivize our engagement in physical activity. At the same time, however, my colleagues and I, while we tend to be on this environmental, psychosocial side of the street, we do not at all ignore the fact that there are genetic, biochemical, and physiological contributions to the development of obesity as well. And I think that most professionals agree that obesity is truly a complex, multifactorial disease. However, if we boil it down to its simplest terms, and this really is a simplification, if not an oversimplification, the reason that the majority of people struggle with their weight is that they are simply consuming more food or more calories on a day-to-day, week-to-week basis than they're burning off in physical activity. It doesn't take much for us to gain weight over the course of a calendar year. So for example, if we do the math, if we consume 100 calories a day more than our bodies are designed to burn off metabolically, the unfortunate reality is that we can gain somewhere between 10 and 15 pounds in a calendar year. And 100 calories isn't a lot. It can be a small cookie at lunch every day. It can be the difference between 3 packs of sugar and half a pack of sugar in your morning coffee. It can be a handful of potato chips. So it really doesn't take much in terms of additional caloric consumption to really put this equation out of whack and lead to weight gain over time. And we have we have evidence that supports this as well. So if we look at the NHANES data over the last several decades, and I want you to focus your attention on this top row, what you'll actually see is that before, in the early 1970s, Americans were consuming less than 2,000 calories per day, which is less than what's recommended by the USDA. If you have a soda in front of you right now or a food label near you, you'll see that those labels tell us we should all be eating about 2,000 calories a day. But look what's happened over time. Our caloric intake has increased steadily, such that as of 15 years ago, we were consuming that 2,200 calories per day, which is why many of us think that that increase in caloric intake has contributed to the growth of the obesity problem we see not only here in Pennsylvania, but around the country as well. We also know that a big driver of this is portion sizes, that in the United States, we are fascinated with large portion sizes and things that are supersized, and that we have a number of different restaurants readily available to us throughout the state and throughout the country that pride themselves on serving large portion sizes, much to the point where we've lost track of what's an actual recommended portion size. So for example, if you look at the two muffins on the screen, many of us, when we get a muffin from a coffee shop in the morning, we expect these very large muffins with large muffin tops, but in fact, those can have almost double the number of calories that's what's typically recommended for the standard size muffin. And yet as consumers, we often feel cheated if we're not getting that large muffin. So we've been brainwashed in some ways to respond to some of the marketing tricks and package sizes that have come out from big food. At the same time, we know that we have become increasingly sedentary. We are far less active than we used to be. And this is an illustration in cartoon form of some of the representations that we see of this. And we heard a little bit about this at the state level in Nathan's presentation, but I also wanted to share with you some findings from studies that have been done within the last 10 years. And what's particularly striking to me about this slide in particular is just how quickly the technology has changed. Because if you look closely at that second bullet point, we're talking about iPods and MP3 players, which very few people use anymore. Many people rely on their cell phones to have their music readily available to them. We don't see much discussion about some of the other pads and technologies that are readily available. And probably most of us on the call have had the experience of being around a child or an adolescent who now will not only sit and watch TV, but may sit and watch TV at the same time that they're watching a second program or interacting with their friends on their smartphone as they lay on their couch. So it's almost a double layer of inactivity as opposed to what many of us did decades ago, which would be to go outside and play with our friends in a local park or in front of our homes as a way to burn calories. So when we begin to think about treatment, we oftentimes will use algorithms that come from federal agencies to help us organize our thinking. And this slide is a little bit dated and has been updated by some recent guidelines in 2013, but I still like using this graphic because I think it really illustrates clearly illustrates our three most common approaches to treatment. So that's diet, physical activity, and behavioral therapy, otherwise known as lifestyle modification. And we're going to focus my remarks on that for the rest of my time. For people with more severe obesity and comorbidities, we have pharmacotherapy, and then we have bariatric surgery as well. But again, I'm going to focus my remarks on lifestyle modification intervention strategies because for many of you working in community settings, this is going to be the approach that you're most commonly going to use with your patients. So when we think about lifestyle modification, there are three main components to it. The first is caloric restriction, where we encourage individuals to reduce their energy intake by anywhere between 500 to 1,000 calories per day, typically by changing and reducing their portion sizes, the amount of fat and sugar that are in the foods they're consuming. We also encourage people to engage in physical activity, and then teach them behavioral modification strategies such as self-monitoring of their weight and caloric intake, as well as monitoring their physical activity. Going through these in a little bit more detail, we encourage individuals to eat and plan their meals and snacks at regular time. And a good rule of thumb is to recommend that people are eating something about every 3 hours. So it would be breakfast at 6 a.m., a snack at 9, lunch at noon, a snack at 3, dinner at 6, and if you're still hungry, a snack at 9. The caloric amounts can vary depending upon how heavy the individual is, but we encourage people to reduce their portion sizes and decrease sugar and fat. And we'll often give people very specific recommendations of how to do that. So to switch from regular soda to diet soda, or better yet, to water. Instead of having 3 pieces of pizza on Friday night with the family, reduce down to 2. Instead of ordering a pizza with pepperoni or sausage, switch over to a vegetable as a way to reduce the calories in what you're eating. We also encourage people to engage in more physical activity, to not only think about programmed activity, which is the way we often think about exercise. So that would be going to a gym or a health club, putting on specific clothes and working up a sweat. But we encourage people, particularly those who have been sedentary, to increase the amount of walking that they do each day. The American College of Sports Medicine recommends that all of us take about 10,000 steps per day, which for those of us who are either wearing Fitbits or have smartphones can easily do and track those behaviors. But the reality is that most people, if they're sedentary, are probably walking somewhere around 2,500 to 4,000 steps per day, less than 50% of what's recommended to help us maintain our weight. And then we also teach individuals behavioral modification strategies. As I said, self-monitoring of caloric intake, changes in weight, physical activity is the cornerstone of treatment, but we also encourage people to engage in stimulus control, slow down their rate of eating, and do some problem solving around places and people and situations that may encourage them to overeat. So one question that people often have is how effective can these weight loss interventions be? And I'm going to very briefly share with you the results of 2 major studies that have been done in the last 10 to 15 years that have shown that these interventions are in fact quite effective. The first is the Diabetes Prevention Program, which asks this basic question of, can a 7% reduction in body weight combined with increasing physical activity reduce the risk of developing type 2 diabetes in individuals who are pre-diabetic? And this was a study of over 3,000 individuals who were clinically obese at a BMI of 34, who were randomly assigned to either receive a placebo medication, metformin, which is a common diabetes drug, or a lifestyle modification intervention, very similar to what we just described. And this slide depicts the weight losses over those 4 years. And as you can see, people on placebo, their weight did not change. Those on metformin experienced a modest weight loss, but those who received this lifestyle modification intervention lost a greater amount of weight and maintained it with a good degree of success over the 4 years. Now, many of you may be looking at this green line and saying, that doesn't seem particularly impressive to me. That's only about 10 to 15 pounds. But here's really, I think, the take-home message from the Diabetes Prevention Program. Here, we're looking at the percentage of individuals who went from being pre-diabetic to diabetic over the 4 years. And as you could see, if you were on placebo, you had about a 37% chance of developing type 2 diabetes over those 4 years, which was higher than that on metformin and higher still than for those individuals who got their lifestyle modification intervention. So one way clinically that you could explain this to people is that if I can help you to lose 7% of your weight, I can reduce the risk that you're going to develop type 2 diabetes by about 60% over the next 4 years. And I think that those are really tangible scientific findings that you can communicate to patients to teach them the value of even a modest weight loss. A more recent study that I was involved in several years ago with some colleagues at the University of Pennsylvania was essentially taking an intervention very similar to what we saw with the Diabetes Prevention Program and seeing if we could deliver it in primary care settings. So could we teach physicians, but more importantly, their staff, their medical assistants and nurses, to deliver interventions in a medical clinic setting rather than a specialty clinic that's tailor-made and designed to deliver obesity treatments. And so we randomly assigned 390 people to these 4 treatment conditions, or 3 treatment conditions. And in fact, what we found is that people who received the most aggressive treatment that we had, which was counseling coupled with meal replacements or medication, lost the greatest amount of weight, which suggested to us that we in fact can deliver these interventions remotely, that we don't have to be bringing weight, we don't have to be bringing patients from a city, a rural area, or across the state to specialty clinics in order to help them lose weight. So in the few moments that I have left, I want to share with you some good news, some promising news, and unfortunately some bad news of the reality of where we're at. So the good news is that several major studies have shown that individuals can lose 7 to 10% of their body weight in about 6 months of treatment, and that these losses are associated with significant improvements in weight-related comorbidities such as diabetes and hypertension. And for these reasons, the American Heart Association and the Obesity Society now consider a 5% weight loss to be clinically significant and an appropriate initial goal for weight loss treatment. Now, in terms of the promising news, several recent studies, sorry, I think I jumped ahead there a moment. Several recent studies have suggested these interventions are feasible and acceptable to cancer survivors. So I've been involved with investigators throughout the state looking at, can we take these interventions and adapt them to major cancer centers to be delivered to cancer survivors looking to lose weight? And in some of these studies, the cancer survivors are achieving these clinically significant weight losses as well as improvements in their comorbidities. But the newest generations of studies, and I think that this is a critically important point looking forward, are now using what are known as e-health or m-health approaches to foster engagement and to reduce the burden to patients. And what I mean by that is that they're using things like websites and web portals, they're using smartphone applications or telephone-based counseling to connect patients to providers so they don't have to be returning to the clinic once or twice a week the way we would commonly see with a commercial weight loss program. Now, unfortunately, these interventions, there seems to be a trade-off. That e-health and m-health interventions seem to produce slightly smaller weight losses than what we see in face-to-face interactions. So we're trading accessibility for the magnitude of the effect of the intervention. Unfortunately, regardless of the approach, approximately 1/3 of patients and individuals regain their weight in a short period of time. And now, unfortunately, we've often blamed this on the patient, him or herself. In reality, I like to think of it as an unfortunate consequence of the toxic environment in which we currently live. That it's just very, very difficult to lose weight and keep it off, given the way that our environment is engineered around food and physical activity. And that this observation really underscores the need to think about weight management, whether we're talking about cancer survivors or the general population, as a chronic, lifelong healthcare behavior. That the idea of we're going to put people on a short-term diet and get them to lose weight and that they'll sustain that for the rest of their lives is really just one that we need to move away from. And then finally, with this last slide, as for those of you who work in clinical settings or provide counseling to individuals looking to work on their weight, this is really just some clinical pearls I'd briefly like you to think about. The importance of using person-first language. So we don't talk about obese persons just like we don't talk about cancer persons. We talk about patients with cancer. We should similarly talk about patients with obesity. The importance of building rapport and providing assessment and treatment in a non-judgmental, open-ended way when we ask assessment questions. And then finally, down at the bottom, I think it's important that we consider referrals to more intensive forms of treatment, such as pharmacotherapy or bariatric surgery, when we begin to hit the end of the road with lifestyle modification approaches. And that thinking about obesity as a chronic disease, it's important that we all practice persistence with patience, that we need to work with our patients, help them make small changes that they can sustain over time, and realize that those changes may in fact take time, and that there may be no quick fix to solve the obesity problem.
Thanks, David, for that really interesting information about obesity and behavior modification and its application to cancer survivors. It really has given us a lot to think about. And unfortunately, we've kind of run out of time on today's webinar. So all of the questions that have come in during the webinar and before the webinar will be answered in written format, which we'll get out to all the attendees via email after this presentation. So, and I also want to just express a word of thanks to all the presenters today to a very informative and timely information on obesity and obesity-related cancers. So thanks to all of you for your time and your information. One last thing. Please take a few moments to complete the very brief survey that will accompany this webinar. And your feedback is really important to us as we look to compile and produce other webinars that are of interest to you. So thanks very much, everyone, and have a great day.